All right, folks, buckle up. Today, we're diving into a world you probably haven't given much thought to. It's capsulectomy specimens.
We're going to be talking about the tissue that surrounds breast implants, and what it can tell us about, well, some pretty interesting medical mysteries, actually.
Yeah, it's like detective work. But instead of a crime scene, we're looking at this capsule trying to find clues about what's been going on in the body, right?
Exactly. And one of the things that makes this so fascinating is this whole link between textured implants and a rare lymphoma called BIA-ALCL.
Breast implant-associated anaplastic large cell lymphoma, BIA-ALCL for short.
The way you handle this specimen, well, it can actually have a huge impact on patient care down the line. So we're going to delve into the anatomy, the orientation, the precise steps for inking and preparation, all of which are absolutely crucial in correctly identifying BIA-ALCL.
So before we get too deep into the detective work, can you give us like a super quick anatomy lesson?
Well, before even touching the specimen, you want to review that patient's clinical history and any imaging reports, right? Are there any signs of fluid buildup around the implant? That would be a seroma. Is the patient reporting any pain, discomfort, any mention of a rash, maybe? These details, well, they can actually be really valuable clues.
Where exactly is this capsule?
Okay, so picture the chest wall.
Okay.
Well, typically you'll have the implant itself. Could be silicone or saline filled, and then that surrounding fibrous capsule. Think of it as the body's reaction to this foreign object. It forms like a wall of tissue around the implant, almost like a protective shell, if you will.
Okay, so it's the body's way of saying, hey, what's this foreign object doing here? But why does the texture of the implant matter so much? Like, why is that such a big deal?
That's the million-dollar question. We know textured implants are associated with BIA-ALCL, and that's whether they're filled with saline or silicone, by the way.
Okay.
But smooth implants, never. It's almost like the texture itself is somehow, playing a role in all of this.
See, that's what blows my mind. You said BIA-ALCL is a lymphoma, but there's often no actual lump to find.
Yeah.
So how do you even diagnose something you can't see?
That's one of the big challenges with BIA-ALCL. Unlike other lymphomas, it rarely presents as like a mass. Instead, what we see is fluid building up around the implant, what we call an effusion.
So is testing the fluid itself the answer? Like, can we look at that fluid and know for sure if it's BIA-ALCL?
Some folks use techniques like cytology or flow cytometry on that fluid, but to be honest, I'm not 100% sold.
Really? Why not? Seems like the logical place to start, right?
Well, the results are often inconclusive. There might not be enough cells in the fluid to really analyze,
Mm.
Or the lymphoma cells themselves, they can be really tough to spot because they look so different, from case to case.
Okay, so you're saying focusing on the capsule itself is a better way to go.
Definitely. The capsule, that's where the action is, so to speak. It's the main site of the disease. And by really examining it, we can get a much clearer picture of what's going on.
Okay, so let's talk about examining the capsule. What are like the key steps? What do you do first?
It all starts with careful grossing. That means we examine and describe the capsule before we even get to the microscope.
Gotcha. So what are you looking for during this grossing process? What are the things that catch your eye?
You carefully examine and describe the capsule. Is it intact? Fragmented? Any tears? Ruptures? Pay really close attention to the inner surface of the capsule. We call that the luminal surface. Is it smooth? Rough? Maybe covered with yellowish, fibrin-like material?
Fibrin. Why is that significant?
Well, that fibrinous material can actually harbor lymphoma cells,
Yeah.
making it a potential hiding spot. So we definitely don't want to miss that when we're taking our samples. And we note the implant, too smooth versus textured, saline versus silicone. These details matter.
It's wild how much info we can get just by looking at and describing the thing, right?
It is. But grossing doesn't stop there. We got to think about how we're going to sample that capsule, where to take those pieces for microscopic examination. And that's where things get, interesting because there are different schools of thought on this.
Ah, yes. This is where we get to compare the MD Anderson approach with the Canadian guidelines. What's the main difference between the two?
Well, MD Anderson, they're like the super sleuths. They recommend inking, like literally inking every surface of that capsule.
Yeah, inking with different colors. Why is that important? What does that tell you?
It's all about tracking. If we see something funky under the microscope, we know exactly where on the capsule that sample came from. It's super meticulous.
Okay, but super sleuth makes it sound pretty intensive, right?
Oh, yeah. On top of the multicolored inking, they recommend taking at least 20 sections. That's a lot of tissue to look at.
20 sections, wow. So what about the Canadian guidelines? They're a bit more streamlined, I'm guessing?
Definitely. They're all about representative sampling. 6 carefully chosen sections should give a good overview.
6 versus 20. That's quite a difference. So which one's better? Is there a clear winner?
Well, it's not that black and white. Both have pros and cons, right? MD Anderson, it's thorough, which could be huge if we're
Mhm.
really suspicious of BIA, ALCL. But it's also a time suck. Might not be feasible for every lab. The Canadian guidelines, they're more practical, but there's always that chance you miss something with fewer samples.
Okay, I see. So it's a judgment call. Kind of depends on the case, the pathologist, and the lab's resources, I guess.
Exactly. No one-size-fits-all answer here.
What about those areas that look suspicious? How do we handle those?
Well, if you see anything out of the ordinary, thickening, nodules, discoloration, absolutely take extra sections of those areas. We want to capture all the potential clues, right?
Don't forget that fibrinous material. That needs to be sampled as well.
Absolutely. Even if the rest of the capsule looks totally unremarkable, that fibrin can be a hiding place for lymphoma cells, so it warrants separate attention.
All right, so we've grossed the specimen. We've figured out how we're going to sample it. What's next? What's the next step in our detective work?
Now we get the tissue ready for the microscope, and here's a key detail. We have to embed the tissue on edge.
On edge. What's that? What on edge?
Imagine a slice of bread.
Okay, I got a slice of bread.
Usually you look at it from the top, right? See the whole surface. But on edge means we're looking at that bread from the side, seeing all the layers.
Oh, I see. On edge. So we're capturing that depth, that third dimension. But why is that so important in this particular case?
Because it's all about depth of invasion.
Okay.
BIA-LLCL staging, it's based on how far those abnormal cells have gone into the capsule. On edge lets us see exactly how deep they've gone.
So it's like seeing how far a seed has sprouted down into the soil, right?
That's a great analogy. This is where it gets kind of interesting. BIAALCL. Well, it's the only lymphoma that's staged by depth of invasion. It's actually a key factor in determining how far the lymphoma has spread.
So unlike other lymphomas where we're looking for spread to the lymph nodes, here it's all about how deeply those abnormal cells have invaded the capsule wall itself.
You got it. And that's why getting those sections perfectly oriented is so critical. It allows us to accurately assess the depth of invasion and assign the correct stage,
Right.
which has major implications for prognosis and treatment.
Okay.
And this info is crucial for figuring out the T stage, for the lymphoma. That's what guides the treatment decisions.
What do we know about what causes BIA-ALCL?
We're still uncovering all the details. But the current thinking is that chronic inflammation around those textured implants is a major player. There's also this fascinating theory that bacteria might be involved, forming these biofilms on the implant surface that further fuel the inflammation.
So our bodies are essentially waging a constant battle against these implants. And sometimes that inflammation goes awry and leads to lymphoma.
That's a good way to put it. And remember, this is the only lymphoma staged by depth of invasion, which really highlights why this meticulous grossing we've been talking about is so incredibly important.
All right, we've carefully grossed our specimen, chosen our sampling method, and made sure to embed it on edge. Now we're finally ready for the microscope, right? What are we looking for at this point?
Now it's histology time, looking at tissues under the microscope. And with BIA-ALCL, there are some telltale signs we look for.
So what are you looking for? What are the signs?
A lot of times you'll see these big abnormal cells hanging out with the regular inflammatory cells. We call them hallmark cells, large abnormal lymphocytes. We'll often find them clustered on that inner or luminal surface of the capsule. They're kind of like the calling card of BIA-ALCL. Not pretty to look at, but that's what we're hunting for.
Hallmark cells. Got it. But how can you be sure those hallmark cells are definitely BIA-ALCL? What if it's something else that looks similar?
Well, that's where a really powerful tool comes in CD30 immunohistochemistry. Think of it like a special stain. It highlights a protein found on those suspicious cells.
So it's like a beacon leading you right to the cells you need to analyze.
Exactly. If those cells light up brightly with the CD30 stain, that's a key diagnostic feature of DIA-ALCL. It helps us distinguish it from other types of inflammation or benign changes.
Got it. We've identified the bad guys.
Exactly. It helps us confirm whether those hallmark cells are the real deal BIA-ALCL or something else entirely.
This is incredible. We started with this seemingly simple capsule, and now we're in a world of microscopic clues and advanced techniques. It's starting to feel like Sherlock Holmes here.
It is a journey. And believe me, we're just getting started. There's still so much more to uncover. Communication between the pathologist and the clinician is so important. You got to look at the whole picture, the patient's history, the symptoms, all the other test results, not just the capsule.
Right. It's all about teamwork. You can't just look at cells under a microscope and call it a day.
Exactly. It's like putting a puzzle together. All the pieces matter.
So we've talked about grossing, sampling, embedding on edge using CD30 immunohistochemistry. Is there anything else that's really key for diagnosing BIA-ALCL from this capsulectomy specimen?
This is super important when we're talking on-edge preparation, figuring out how deep it's gone. If you only take a few samples and they happen to be from areas where it hasn't penetrated very deep, you might underestimate how bad it really is.
So more samples equal a more complete picture,
Ah,
especially in terms of how far that lymphoma spread within the capsule.
you got it. And that depth of invasion, that's what determines the PT stage.
Okay, got to break that down for me. PT stage.
Yeah.
What's that and why is it so important?
So PT stage, it's part of the TNM staging system. That's how we classify how far a cancer has spread. T for the tumor itself, with stages ranging from T0 to T4. Each stage reflects how far those lymphoma cells have traveled from their starting point on that inner capsule surface. Think of it like layers of a wall, with the innermost layer being the least worrisome and the outermost representing the furthest spread.
Okay, I'm intrigued. Let's take it layer by layer. What does T0 mean?
T0 means the lymphoma cells are only present in the fluid surrounding the implant, not in the capsule itself. They're essentially floating around, haven't invaded any tissue yet.
So they're present, but they haven't breached that first line of defense.
Exactly. Then we have T1, where the tumor cells are confined to that inner or luminal surface of the capsule. They've gained a foothold, but haven't penetrated deeper.
Okay, so they're contained to that first layer. What about T2?
T2 is where things start to get a bit more concerning. Here, the tumor cells have broken through that first layer, and they're starting to invade deeper into the capsule wall.
So we're seeing actual invasion now. What about T3?
T3 represents deeper invasion. Those lymphoma cells are pushing further through the capsule wall, potentially getting closer to surrounding tissues.
And I'm guessing T4 is the most serious.
You got it. T4 means the tumor has extended beyond the capsule itself, invading into the surrounding breast tissue or even further.
Wow. So staging really paints a clear picture of how far this lymphoma has progressed.
It does, and that's why getting those sections oriented correctly, with that on-edge view, is so critical. It allows us to accurately determine that depth of invasion and assign the correct T stage, which, again, has major implications for the patient's prognosis and treatment plan.
Are there any particular pitfalls or gray areas we should be aware of when determining that T stage?
I think the biggest challenge, in my opinion, lies in accurately assessing the depth of invasion, particularly when you're dealing with fragmented or distorted specimens. Remember, we're relying on those meticulously oriented sections to tell us how far the lymphoma cells have actually penetrated that capsule wall.
Right, those on-edge sections are key.
Yeah,
But what if the capsule is torn or shredded? Does that make staging more difficult?
absolutely. It can be a real puzzle trying to reconstruct the original architecture and determine the true extent of invasion.
Wow. So all this careful grossing, sampling, embedding on edge, meticulous staining, it's all about staging the lymphoma accurately and giving the patient the best chance.
Got it. It's all connected.
You mentioned before that some people use like cytology or flow cytometry on the fluid that builds up around the implant, but you're not a huge fan of those methods, right?
Right. They can be helpful sometimes, but honestly, they often aren't sensitive or specific enough to give you a slam dunk diagnosis of BIA-ALCL. For flow cytometry, which looks for specific markers on the surface of lymphoma cells, it can be tricky when it comes to BIA-ALCL. The results are often inconclusive, and we risk missing a true diagnosis.
So it's not giving us that definitive answer we need. And what about cytology? Looking at the cells under the microscope.
Cytology can be helpful for identifying those characteristic large abnormal lymphocytes of BIA-ALCL. However, it can't tell us how deeply those cells have invaded that capsule wall.
And we know that depth of invasion is crucial for staging, right? So if those techniques aren't the gold standard, what is?
Histopathology and immunohistochemistry. They're the dynamic duo that give us the most accurate and definitive diagnosis.
So you're saying relying on fluid analysis alone could be risky, could give a false sense of security.
That's my concern. That's why I'm a big advocate for focusing on that capsule. That's the main battleground. And if we carefully examine it using those techniques we talked about, we get the most reliable info for diagnosis and staging.
Wow. This is eye-opening. I had no idea there was so much nuance to diagnosing BIA-ALCL from a capsulectomy specimen.
It's a fascinating area, and we're still learning new things all the time. It's constantly evolving.
So if I'm getting this right, the gold standard is really meticulous grossing, generous sampling, on-edge prep, and accurate CD30 immunohistochemistry. Fluid analysis can be a backup, but not the main event.
That's a great summary. And remember, it's all about teamwork, the pathologist, the clinician, everybody working together to ensure the most accurate diagnosis and the best outcome for the patient.
This deep dive has been a real eye-opener. I mean, who knew that tiny details like the texture of an implant or how a tissue sample is prepared could have such huge implications?
It really highlights the power of just careful observation, and scientific rigor and collaboration in medicine. It's fascinating.
Speaking of collaboration, how do pathologists and surgeons actually work together when it comes to these capsulectomy specimens? Do they talk a lot? Is there back and forth?
Oh, yeah, absolutely. Communication is key, right? The surgeon might have a hunch based on what they saw during the procedure, and they'll let the pathologist know, hey, look out for this. And the pathologist, if they find something weird during grossing or under the scope, they'll flag it for the surgeon. Hey, did you notice this?
So it's a two-way street. Both sides sharing information and insights to make sure the patient gets the best care possible.
Exactly. It's a team effort for sure.
This deep dive has been a fascinating journey into, well, this whole world of capsulectomy specimens and diagnosing BIA-ALCL. But before we wrap things up, I have one last question.
Yeah.
You've talked a lot about being thorough in examining these specimens, but how do pathologists balance that with, practicality? Especially when lots of labs have limited resources. That's got to be a challenge, right?
Oh, for sure. It's a balancing act. We got to be thorough, but we're also mindful of time, and we got to make sure we're using resources wisely.
So how do you navigate that tension? It's a tough spot to be in, I imagine.
Well, communication is key. Talk to the surgeons, understand their level of concern, and then figure out the best sampling approach for each case. Within the lab, prioritize, allocate resources where they're needed most based on urgency and suspicion levels.
So it's all about making smart choices, considering the specifics of the case and the resources you have available.
Exactly. And we also rely on those established guidelines like those Canadian recommendations we talked about. Those help create some consistency in sampling. They help us find that balance between being thorough and being practical.
So you're not just randomly slicing it up.
Nope, not at all. We really scrutinize the capsule, looking for any thickening, discoloration, anything out of the ordinary. And then we take sections from each surface, front, back, sides, top, bottom, making sure each section includes both the inside and outside.
Gotcha. And you mentioned on-edge embedding before.
Remember, we stage BIA-ALCL based on how deep it's invaded. On-edge embedding lets us see exactly how far those lymphoma cells have gone, like a cross-section. And that's how we determine the T stage.
This has been such a fascinating exploration of the whole capsulectomy specimen world. This deep dive has been a real journey. Most people have no clue about this world, but it highlights how critical pathologists are in making sure diagnoses are accurate, even for these rare conditions. It's amazing.
It's been great sharing this with you and the listeners. It really is a fascinating field.
And I think our listeners are walking away with a whole new appreciation for what goes on behind the scenes in those pathology labs. It's intricate work.
I hope so. It's a critical part of medicine. Absolutely. Knowledge is power, right? The more you know about this whole process, the better equipped you are to advocate for yourself, make good decisions about your healthcare.
Well said.
Yeah.
Thanks for joining us for this deep dive, everyone. We'll see you next time for another adventure in knowledge and discovery.
It really shows you the power of pathology. I mean, we're often working behind the scenes, but we're a crucial part of the diagnosis, treatment, and making sure patients get the best care possible. It's a vital role.
Well said. I think that's a perfect way to wrap things up. Thanks for joining us for this deep dive into the world of capsulectomy specimens and BIA-ALCL. Until next time, happy grossing.